The authors have no financial interest.
Early recognition combined with advances in instrumentation have enabled effective management of posterior capsule rupture and vitreous loss during phacoemulsification. Posterior capsule rupture can occur at any stage of phacoemulsification. For example, during hydrodissection, nucleus removal, cortex removal, posterior capsule vacuuming, and during IOL implantation as well. Failure to manage the PC rupture and the vitreous loss correctly can lead to cystoid macular edema, retinal detachment, secondary glaucoma, and even postoperative endophthalmitis as well. Anticipate PCR in a patient with traumatic cataract, cataract post-vitrectomy, posterior polar cataract, hard brown cataract, cataract with pseudoexfoliation, etc. In this animation, you can see the vitreous acts like a slinky. When there is a posterior capsule rupture, when there is a coaxial irrigation aspiration, which means that irrigation and aspiration are the same port, there can be an extension or enlargement of the posterior capsule rupture and more hydration of the vitreous, and more vitreous will start coming into the anterior chamber. In the presence of a posterior capsule tear, then the tear gets tamponaded by the anterior chamber maintainer, and there is no hydration or very minimal hydration of the vitreous, thus allowing us to do the anterior vitrectomy or remove the vitreous from the pupillary area and the anterior chamber very effectively. Once you have a PC tear with vitreous loss, there are 4 important things we have to remember. Number 1, vitrectomy cutters, 20 gauge, 23 gauge or 25 gauge. Number 2, bimanual vitrectomy. By bimanual I mean there is a separate anterior chamber maintainer and a separate port for the cutter. Number 3, limbal anterior vitrectomy or pars plana anterior vitrectomy. Number 4, use of preservative-free tricot in the anterior chamber to delineate the anterior vitreous for the anterior vitrectomy, either through the limbal or the pars plana route. This video shows how, in the presence of a posterior capsular rupture, that we should not pull out of the eye. As you can see here, the sudden pulling out enlarges the PC tear and more vitreous starts coming into the anterior chamber. And you can see that nucleus bit has also gone into the vitreous cavity. This video shows an anterior assisted levitation of the nucleus, wherein the nucleus is brought into the anterior chamber and delivered through an enlarged limbal incision. Preservative-free tricot is being put into the anterior chamber, followed by an anterior vitrectomy and followed by an implantation of an anterior chamber IOL with excellent postoperative visual recovery for this patient. In this case, a posterior assisted levitation or PAL, wherein the nucleus is retrieved through a pars plana sclerotomy and introducing a rod through the pars plana and levitating the nucleus up into the anterior chamber. This is called the posterior assisted levitation, PAL, wherein the entire nucleus is brought up into the anterior chamber and delivered by enlarging the limbal incision. The vitrectomy mission, all the phaco missions are providing with the posterior vitrectomy cutters, which are either 23 gauge or 25 gauge, which enables us to do the vitrectomy through the pars plana sutureless. The trocar and cannula system can be a little tricky. The trocar and cannula system has to be introduced through the pars plana, which is about 3.5 millimeters, posterior to the limbus. Always apply a suture in the main port or fill up the entire anterior chamber very tightly with viscoelastics. The other option is to do a sclerotomy with a myringotomy knife and introduce a 20 gauge vitrectomy cutter. The only problem with this is that we can't leave this sclerotomy sutureless. We need to put a suture for this sclerotomy since it is of a larger size. A case of posterior polar cataract, wherein the same principle is followed. There is a dehiscence in the posterior capsule, and I can see the two typical pillars in the posterior capsule, which is very typical of posterior polar cataract with pre-existing dehiscence. Again, keeping the anterior chamber maintainer, introducing viscoat into the anterior chamber and doing an anterior vitrectomy, and then removing the cortex in the epinucleus and putting a multi-piece lens in the sulcus and capturing the optic of the lens into the capsulorhexis margin. This is called the optic capture, which ensures a long-term stability of the lens and also prevents UGH syndrome, since the IOL is located actually in the bag, the haptics in the sulcus. Once you have managed the PC tear and the vitreous loss very competently and effectively, then if the PC tear is small, then we can go ahead with a single piece lens in the bag. If the PC tear is large, then we have to go in for a multi-piece lens in the sulcus with an optic capture, or go for a retro-iris fixated lens, or a secondary or a primary glued IOL, or a sutured scleral fixation IOL, or even an anterior chamber IOL, making sure a peripheral iridectomy is being done for patients with anterior chamber IOLs. The take-home message is PC tear and vitreous loss are not uncommon. They can occur even to the experienced surgeons. Anticipation of the PC tear, recognition of the PC tear, and management of the vitreous is very important for the good outcome and long-term outcome for these patients.